Good morning, everybody. It is a pleasure to be here. I'm Mitch Mitchell, Chair of the San Diego Housing Commission Board of Commissioners, and it is currently 9:03 a.m. on September 16th, 2022, and I'm going to call to order the special meeting of the board. The process we are using today is for today's meeting is authorized by Government Code Section 54953, which was added by Assembly Bill 361. This allows the Housing Commission to use teleconferencing and provide the public with an opportunity to address the board through a call-in or internet-based option during a proclaimed state of emergency. The San Diego City Council on September 13th, 2022, declared that the state of emergency continues to directly impact the ability of members to meet safely in person. The council also declared that this applies to all boards, commissions, and committees of the city of San Diego. This meeting is occurring by video conference with all board members, our interim president and CEO of the Housing Commission staff, and general counsel participating by video. For the record, I will ask each board member to indicate your presence as I say your name. Vice Chair Ryan Klumpner.
Here.
Commissioner Stephanie Benvenuto. Commissioner Joanna Hester.
Here.
Commissioner Kelly Hubbard.
Present.
Commissioner Melinda Vasquez.
Here.
Wonderful. No members of the public are in attendance. However, members of the public may watch the video conference here and hear the audio of today's meeting, which is being streamed live online. The agenda for today's meeting included a link to the website for the San Diego Housing Commission Board of Commissioners, where the public can access the live streaming for today's meeting. The public has been provided with an alternate number opportunity to provide comments to the board through an online comment form and a toll-free number. A link to the online comment form was included on the agenda for today's meeting, which was posted on the San Diego Housing Commission website at www.sdhc.org on September 14th. The agenda and public comment form explain the comments about items on the agenda and will be read into the record if they are submitted by 4 p.m. yesterday, September 15th. Non-agenda public comments submitted by 8 o'clock this morning will also be read into the record. In addition, members of the public who wish to speak on an item may call the toll-free number that is included on the agenda. Members of the public should monitor the meeting through the video streaming available through the Housing Commission's website. That is, again, once at www.sdhc.org. Again, today's agenda includes a link to the website for this board where the public can access the live streaming for today's meeting. Members of the public should call the toll-free number only when the item they wish to comment is introduced. If the caller begins to comment on an item that is different from the item that is currently being considered, they will be asked to hang up and call back into the meeting at the correct time. Members of the public will have 3 minutes each to provide their comments. However, if a large number of callers wish to speak on a single agenda item, the comments will be limited to 1 minute each. During non-agenda public comments, we will now proceed with the non-agenda public comment portion of the meeting. The phone line is now open to provide non-agenda public comments. Please call 833-610-2513, the number that you see on the screen, to be placed in the queue. The phone line will be open for 90 seconds to allow time for members of the public to call in. And this is a time when members of the public may provide comments to the Housing Commission Board about topics that are not on today's agenda, but involve a subject within the Housing Commission's area of responsibility. The Housing Commission cannot take action on non-agenda public comments. The number, once again, is 833-610-2513. We did not receive any written non-agenda public comments for today's meeting, and I will now ask Scott Marshall, our Vice President of Communications. Scott, do we have any callers for non-agenda public comments?
We do not have any callers at this time. We have about 45 seconds left on the clock.
Okay. We will await the end of that period of time.
The time has concluded and there are no callers.
Thank you, Scott. This concludes the non-agenda public comment portion of the agenda. I will now move to the commissioners. Commissioners, any commissioner who would like to make any comments, please signify by letting me know. Commissioner comments. Seeing none, then we will move to this morning's item and agenda. This morning, we have one item for discussion, and the PowerPoint presentation was emailed to the commissioners yesterday, September 15th, and is posted on the Housing Commission's website. And the item is item 100, the consideration of the approval of an agreement between the Housing Commission and People Assisting the Homeless to operate the City of San Diego's multidisciplinary outreach program. The phone line is now open for public comments about item 100. So again, please call 833-610-2513 to be placed in the queue. No written public comments were submitted regarding this item. And again, the number is 833-610-2513. We will take public comments about the staff presentation, and that presentation will be led by Vice President of Strategic Initiatives, Lisa Jones. And she will also, she is all with the Special Programs Manager and Senior Policy Advisor, Jonathan Herrera. So Lisa and Jonathan, please begin when you are ready to go.
Thank you. Good morning, Chair Mitchell and Commissioners. We're here today to present staff's recommendation to approve the fiscal year 2023 agreement between the San Diego Housing Commission and People Assisting the Homeless to operate the City of San Diego Multidisciplinary Outreach Program. Next slide. During the fiscal year 2023 budgeting process, the City Council allocated $500,000 to the Housing Commission for the purposes of creating a multidisciplinary outreach program. This program builds upon the strength of the City of San Diego's coordinated outreach program, for which the city's Homeless Strategies and Solutions Department recently took over administration. This new program strengthens the overall coordinated outreach strategy that was developed over the past several years and addresses a critical service gap in the crisis response system. The service model is informed by industry best practices and will provide services in alignment with regionally adopted community standards. The multidisciplinary outreach program also supports the vision and implementation of the Community Action Plan on Homelessness for the City of San Diego, which identifies increased access to behavioral health resources, along with other health and human services as an essential element in the system's ability to meet the complex needs of persons experiencing homelessness. Next slide. The primary focus of the multidisciplinary outreach team is to identify and engage individuals experiencing homelessness who are the most vulnerable and have the greatest behavioral and/or physical health needs. So a smaller targeted portion of the overall homelessness system. This includes individuals with severe mental illness, a debilitating level of substance use, as well as those with severe co-occurring conditions. Due to the high acuity of the target population, they are often among the most frequent utilizers of emergency systems, such as 911 and emergency rooms, or have frequent encounters with law enforcement as a result of mental health issues or substance use. The service model will utilize data from existing systems of care to best identify the target population. This includes coordinating with a variety of crisis response teams, including the Psychiatric Emergency Response or PERT team, emergency medical response teams such as the Resources Access Program or RAP team, mobile crisis response teams, and law enforcement partners, as well as communication and coordination with the city's coordinated outreach program teams. The program model is tailored to meet the complex needs of the target population with the goal of supporting the client in accessing services while providing ongoing intensive continuity of care and case management. This program over time will also reduce pressure on other programs such as the neighborhood-based outreach and rapid response teams and other crisis response activities by focusing intensive care on the very highest need individuals so those other resources may be less taxed. Next slide. As part of the service model, PATH, the recommended operator, and Father Joe's Villages, their program partner, will deploy an integrated multidisciplinary outreach team, providing case management, care coordination, including primary health and behavioral health care, system navigation and housing-focused services, as well as post-placement case management stabilization assistance to support housing retention. The program utilizes an integrated multidisciplinary team that will include a nurse practitioner, 4 clinical outreach specialists, a medical assistant outreach worker, 2 peer support specialists, and a part-time substance abuse counselor. Father Joe's Villages will also leverage support from several members of its street health team and village health clinic to increase access to services. These include access to Father Joe's Villages psychiatric nurse practitioner and clinical psychologist, as well as other healthcare professionals. Next slide. A key feature of the multidisciplinary outreach team in comparison to existing outreach activities is that service delivery will be person-based and not location-based. The team will strategize with emergency care systems and city-funded outreach programs to identify members of the target population and develop a prioritization list. So the team will engage wherever the person in need of their services is versus having a specific geographic area of coverage. Client engagement activities will focus on building trusting relationships through street-based case management to coordinate care. Mental health clinicians and nurse practitioners will assess mental health and medical care needs while connecting the client with ongoing care to improve client stability. Through this service model, biopsychosocial assessments and medication-assisted treatment will be able to be provided along with care coordination for additional primary care, mental or behavioral health services, and substance abuse counseling. This level of intensive engagement also stays with the client over time to support stabilization, essentially following the client through their instance of homelessness, whether the individual is living in a place not meant for human habitation, in a shelter, or transitioning into permanent or longer-term housing options. The multidisciplinary outreach team will be a constant resource for the client's care and will work toward maintaining the continuity of care across various support systems or housing options until a stabilized handoff can occur. Due to the intensity of service needs and constant and consistent engagement for this population, we anticipate the team to serve 20 to 25 individuals at a time and approximately 50 individuals in a year. Next slide.
On July 7th, 2022, the Housing Commission issued a request for proposal seeking an operator for the multidisciplinary outreach team. The RFP was posted and made available for download on the Planet Bids website through both the Housing Commission and the City of San Diego's portals. 730 notifications were sent through the Planet Bid system, and 30 prospective bidders downloaded the solicitation. On August 4th, the RFP closed, and PATH was the sole respondent. A selection committee evaluated and scored the responses based on the service model, case management services, care coordination activities, equity and inclusion, cost proposal, and the organization's experience and capacity. The review process also included an interview of the proposer. PATH's proposal was deemed a responsive and strongly qualified response that met the expectations of the RFP and was recommended for award by the evaluation committee. The proposal is a joint venture by both PATH and Father Joe's Villages, whereby PATH will serve as the fiscal agent and lead on street-based case management activities, working in close coordination with Father Joe's Villages health clinic staff to triage healthcare needs and provide primary care, mental health, behavioral health, and substance use disorder counseling. Next slide. PATH has been serving individuals experiencing homelessness for 37 years, with operations spread across the state. PATH first came to San Diego in 2013 as the selected operator for Connections Housing, a city-funded shelter program in downtown San Diego. On an annual basis, the organization serves more than 4,200 individuals across the region. In recent years, PATH has established itself as a local leader in providing outreach services, where they have been at the forefront in the transition of outreach activities to a more housing-focused and client-centered model. Speaking to this level of expertise, PATH currently operates multiple outreach contracts throughout the county, which include the City of San Diego's Coordinated Street Outreach Program, City of La Mesa's Street Homeless Outreach and Mobile Engagement Program, contract with the County of San Diego for the San Diego Homeless Outreach Program, as well as an agreement with the Regional Task Force on the Homeless for the San Diego Enhanced Outreach Team Program. Next slide, please. Father Joe's Villages serves more than 14,000 men, women, and children annually, and has been providing services for individuals and families experiencing homelessness for over 70 years. The organization currently operates multiple city-funded shelter programs, including the Bridge Shelter at Golden Hall, the Paul Morable Center, the Neil Good Day Center, and the Bishop Maher Center. Father Joe's Villages offers a comprehensive portfolio of supportive services through their campus in East Village, where clients can access a federally qualified healthcare center for access to medical care, dental care, and behavioral health care, substance use disorder counseling, employment readiness, educational opportunities, and vocation training, as well as therapeutic childcare services. Next slide. Operating costs for the initial contract term are $632,013 for the 9-month period from October 1st, 2022 through June 30th, 2023. This includes $624,750 in operating costs and $7,263 in ramp-up supplies. Overall program costs also include $62,475 for Housing Commission program coordination and administrative costs. Funding sources include city's general funds and homeless housing assistance and prevention program funds from the Regional Task Force on Homelessness. Future contract terms will be exercised contingent on funds being allocated for this purpose during the City and Housing Commission fiscal budgeting process. Next slide. Housing Commission staff request that the Board of Commissioners recommend that the Housing Authority of the City of San Diego take the actions detailed in the staff report and shown on the following slides. Next slide. Next slide. That concludes our presentation. We are joined by Hanan Scrapper with the PATH, Regional Director of San Diego PATH, as well as Thomas Lavelle, Acting Director of Government Relations and Grants with Father Joe's Villages. Thank you, and we're available to answer any questions.
Okay, so we will now take any public comments from callers who are on the line for the specific items. Scott Marshall, do we have any callers at this time?
We do not have any callers. Thank you.
All right, this concludes the public comment period for item 100. Commissioners, do you have any questions about this proposed contract and subsequent potential approval on this item? Commissioner Benvenuto.
I'll defer to him.
Okay, Commissioner
Go right ahead.
Okay. Thank you for the presentation, everybody. I want to start just by saying PATH obviously has a very strong background, great presence here, all of those things that we can generally agree on. I am disappointed that there was only one response. I think that we've circled around this discussion and we know the issues, but I just want to keep bringing that up to the forefront, especially as we're talking about the study on pay and all of those things about really thinking about the workforce, which leads me to my question. First, a few. How are we feeling? How confident is staff and PATH and Father Joe's on having the staff to do this work? This is exceptionally intensive work. I imagine that recruiting folks for these roles could be a challenge. Want to make sure that we're confident we're going to have the bodies to execute.
Right, absolutely. We feel fairly confident because this particular area of work is a place where PATH really is the leader and excelling in outreach. So folks that want to do this kind of work are, frankly, I think, being attracted to PATH for that purpose. They also have a really good team, and Director Brian Gruters from PATH is on as well, who leads their outreach efforts. And from the Federally Qualified Health Center standpoint, Father Joe's Chief Medical Officer, Dr. Jeffrey Norris, is really one of the leaders in the country around homelessness, primary medicine and care, and launched one of the early street medicine teams. So we weren't surprised and actually quite grateful to see this partnership come forward. We saw definitely PATH and Father Joe's street medicine team as really leading in this space. Frankly, to your point, Commissioner, there's very few other agencies that could sort of pull these two unique specialized resources together. But I also want to give a chance for Hanan or Thomas, who are on the line, to speak to your question directly.
Thank you, Lisa. Staffing is always going to be a concern for us right now, especially as an organization. We are working on a comp analysis study to really determine where our pay needs to be to attract employees who would really want to do this work. One thing we do offer is that we do have clinical supervision for the clinical staff who would come in, which is really lucrative for people to be able to get that as they work towards their licensure. And when we were thinking about the staffing model, we really wanted to use also whole person care or Project 25 as like being successful programs that we've seen, to have a small caseload ratio, being able to work with folks and really like from all the steps of the system response, and being able to get them into housing and provide those clinical supportive services. So we feel pretty confident, especially for a program like this, that it will attract a lot of applicants who would be really interested in working with the population. And I don't know if Thomas or Brian want to add.
Thank you, Lisa and Hanan. Father Joe's Village is in total agreement. We're really excited about this project and the partnership with PATH if we're to be selected. This is very exciting. Our Village Health Center has a robust staff, and finding the best, most highly qualified candidates has been one of our top priorities over the past year. And we have several candidates already in mind. And as an expansion of our street health program, we really feel that this will attract the best candidates, and we're keeping that a top priority. But understanding that staffing concerns are definitely top of mind, and this has been one of the biggest conversations around the project, and we're moving fully forward to address all the concerns that many organizations are facing right now. But we are very excited about this.
Okay.
Thank you. Another question. With the signing of with the signing of the Care Court bill, this seems like it would be a perfect launching ground for what could work with coordination with regard to Care Court. Is there any early discussions about how this is going to be, stage one infrastructure potentially?
Yeah, that's actually part of the conversation for sure. In fact, I mean, the fact that biopsychosocial assessments can be done in situ rather than expecting people who don't have the ability to walk into a clinic and choose services to do that is going to be really important. One of the challenges around Care Court and any form of conservatorship is that it's a really high bar to prove the need. So what this will help us do is, where the need is there, be able to prove it through ongoing documentation through this street-based engagements, but also where we really don't know whether that's the need until people get connected to the services and supports they need, really identifying the folks that with this right kind of intervention can stabilize on their own. So really getting down to that very narrow space where Care Court and or conservatorship might be a requirement.
Yeah, that's great. Thank you. And to that point, if staff hasn't, I would encourage you to just make the hospital association aware of this effort. I think that they would, given their tension around Care Court and what's coming for them, the knowledge of this sort of infrastructure being out there and getting launched could really help them just have a better idea about what's happening out on the ground. And then finally, well, actually, before I go into my last question, I failed to say that I am very grateful for this program. Thank you for bringing it forward. It sounds fantastic. And I love how you are integrating all of those pieces to get to those folks that we are desperate to get to. But to that aim, is there a number of individuals that would, we want to serve X number of people and that will determine success? Or with these funds, we anticipate being able to serve X number of people? What's the metric?
Yeah, thank you. And I realized that I thought that was in the talking points, but maybe I missed it. We were just finishing them last night. So it's a really great question. So, so to be really frank and to talk about, and this actually relates to the staffing model, we're looking at higher level clinical staff. They're really who are being targeted for this team, right? It's a high level of expertise and need, which means frankly that there's this is an expensive program, but it's an expensive program that's a whole lot less expensive than probably the emergency care and constant crisis response that's currently happening, right? So it'll reduce pressure on that system. These case management ratios are 1 to 5. So very low case management ratio, because this is really an intention of ongoing daily engagement, not checking in on someone once a week, but day after day, sometimes multiple times a day, depending on what's going on. So these are 1 to 5 case management ratios. The anticipation is at any given time, the team is serving 20 to 25 individuals, which is probably going to equate to about 50 individuals a year. And if you kind of do the math of the proration, this equals to about $1 million a year program. But the real goal then will also be, there are programs at the county, there's Project One for All vouchers that we have, there's ACT level housing and housing for high level SMI that sometimes go underutilized because it's so hard to prove the need. and make the eligibility requirements. So that's another thing that this team will be able to do so that we can better access and utilize those services. And we're already having conversations with County Behavioral Health around how we coordinate together.
We'll most definitely be in support. I look forward to hearing the lessons learned on this one. Thank you.
Thank you, Commissioner. Commissioner Klempner.
Thank you. I was happy to have Commissioner Benvenuto go first because, as expected, she asked some fantastic questions I hadn't thought of. That
I was trying to get
this.
you. I was trying to get you in first, so because I used to always know that she's going to make me look bad that I missed something. But
Yeah, so you can watch
man,
me flail
I'm
around before she comes in with the great question. Yeah. So thank you for all that background. That's extremely helpful. I kind of have a couple sort of follow-ups here. One, so I really appreciate this I don't know if this is a shift necessarily, but the focus on the person-based rather than the location-based approach. And I kind of have some questions about how we are identifying the target population here. And I guess here's sort of what I was wondering: is this a matter of taking existing information we have about this population, and then we're creating a list of individuals that we are attempting to serve? Or is this more like a criteria that as we engage with people, we are filtering into this program? Does that make sense?
Yeah, I think actually both Jonathan and Brian can speak to that. Jonathan, do you want to kick it off?
Thank you. Yeah, so it's going to be primarily the former scenario, using all of those systems of care who are engaging this very same population, high users of emergency systems, and really trying to, from that data sets, synthesize who are those individuals that would meet the target criteria. And then from that, building this roster. So from that list, we could then begin prioritizing and operationalizing outreach activities. And we do that to some degree right now within the current system, but it's really, it excludes these individuals that have these high levels of need, simply because outreach teams aren't able to meet that capacity. So this by name list will be very targeted, and again, informed by all of these other systems of care, which is unique. And one thing that's really going to be different from the case management activities is that continuity of care that Lisa was speaking to, is that these outreach teams are going to be following clients across their entire journey, from the point of time that they meet them on the streets to helping them get into shelter and helping them get into housing. Because a lot of the times we see these individuals fall out or fail out from those systems, and then we're trying to re-identify and re-engage them. So these outreach teams will be that one constant presence throughout their instance of homelessness.
Well, I think that highlights too, Jonathan, the real difference between crisis response and ongoing intensive engagement, because all of the other sort of entities that engage with this particular population, it's a one and done. It's a crisis response, and then admitted to the emergency room, crisis response, admitted to the psychiatric hospital, but then they fall back out, they get discharged. And so there's those crisis response teams don't have the bandwidth or really the mission statement to just continuous working with them. So that's where this will really bridge a gap. Ryan, is there anything you wanted to add? You're always so articulate. I'd hate to not give you the chance.
I don't know about that. Well, I would just say, we do a lot of outreach, and we see this kind of as a missing piece. It's, if you imagine, your general population of people living unsheltered, it's the big pool of folks. We see that population. We have a team that works with that group. And then we have another team that does street-based case management. So a subset of that group gets more care. And then I think what we found is that within that group is an even smaller subset of folks who, the general solution for that second group is something like permanent supportive housing, things that we're able to provide pretty readily now with that team. But this smaller group, it's even more challenging, because these are folks who, may not even be willing to sign a lease when we get them to that point, or they may not be willing to get in a vehicle and go to the lease signing appointment, things like that. So they need even higher levels of care than what we can currently provide. And I think that's another, I think we see that informing this population that we intend to serve as well.
Okay.
Yeah, thank you. That's very helpful. Appreciate that. Yeah, and there are a few things more heartbreaking than seeing somebody in a state of crisis with a hospital band on their wrist, which we have all seen. And so, you know, I think in simplest terms, that's kind of what we're focusing on here, is the reason why we see people go directly from one crisis to another. And, you know, the really important role, I very much appreciate this progress here. And yeah, this is really kind of focusing on, you know, one end of the impossible trade-off that we're always dealing with, which is, you know, we know numerically that people experiencing homelessness, most of them, it is an economic situation that we're dealing with. They are not high visibility, you know, they are in some form of, you know, unstable shelter. And that's a difficult thing to explain to the public, because we all know that when we hear from the public, really what they're describing is this population, which is a different undertaking than, you know, the numbers that we're aware of. And so, yeah, I'm hopeful that, you know, both just kind of on a basic, you know, mission statement, you know, this is the population with the greatest need, I think, is one way to look at this. And so it's fantastic that we're addressing that. And then, you know, also just in terms of, you know, this is the thing that I think sticks in people's minds when they see it around them the most. And so hopefully this is one of those programs that the investment here translates into, you know, people can perceive some difference in the situation. One more question I have on this, which is, given that this is person-based as opposed to location-based, how much of a challenge do we think it may be when people move locations to re-identify them? Because I think one of the failures of location-based services is that it prevents that continuity that is the purpose of this whole program. But one of the things that makes it, I think, more manageable is that if you have a location-based service, you're not attempting to locate somebody who has moved somewhere else. You're just focusing on who's there right now. And if somebody moves, they're not your problem anymore. And that is clearly, there's a major problem with that, you know, with limiting ourselves to that approach. But I'm wondering how much of a challenge we think that you know, keeping up with the locations is going to be. And in particular, related to that, do we anticipate enforcement actions to be impacting that task? And you know, how will we be sort of tracking whether that is making it harder to actually provide the services?
So I'll start, and then I think I'll hand it over to Brian, if that's all right. So from that perspective of person-based, I think that's why, frankly, coordination between the different outreach teams is going to be so critical. We know that PATH, on behalf of Homeless Strategies and Solutions Department, oversees coordinated outreach and the rapid response team. So a communication between these crisis response teams and between the neighborhood-based outreach teams is going to be critical. Obviously, with PATH's infrastructure and really now taking on both of these areas of work, they're going to have that internal communication that can happen. But part of the coordination role for the Housing Commission is going to be making sure that we're creating good communication strategies between all these different types of teams. So when someone sort of falls off the map, we can find them again, right? And it'll be clear within HMIS that that person is enrolled in this particular team, so that when, for instance, we lose track of them and then the RAP team or the PERT team gets involved, you know, there's this awareness that they know what the case management load is and who this team is case managing, so that they can hand them back off. Is going to be really important.
Do we anticipate there being some like forward-looking communication with enforcement actions, so that, you know, individuals enrolled in this program, we know ahead of time and we don't discover that there was a cleanup and we've lost track after the fact?
So HSSD has been very committed to working with us around both their focused outreach events, their coordinated outreach team, and obviously they work closely with law enforcement and neighborhood policing around that as well. Jonathan and I both participate in regular meetings with the mayor's office so that when they're doing a particular ESD activity or something of that, we do know ahead of time. So we'll make sure that we sort of have that in place. Obviously, there's always can be some potential impact, but knowing ahead of time so that the teams can be working with those clients is going to be critical.
Great. Thank you very much.
Thank you, Vice Chair Klempner. Commissioner Vasquez.
Hi, yes. Thank you, staff. I'm happy to see that wraparound services are making a segue to housing and the Housing Commission. I know Casey Families has opted for that instead of removing children from homes that need behavioral changes. It just keeps people where they need to be and provides the crutches, let's say, that they need in order to get through whatever trauma that they've experienced. And so the question that I have is, I know when people receive social services in general, and they start making headway towards getting a job and start earning income, then all of a sudden, if they're at a zero, very low or a poverty level income, to qualify, that as soon as they start making some money, then that automatically excludes them from receiving additional services. And we all know that, right? Like even starting a new job can be so stressful and have all these different types of conflicts that we would still want those wraparound services available to people that are heading down the right path or heading down the path of autonomy. And so how will these residents be affected by if they start progressing down a more sustainable path,
Right. So,
with jobs, et cetera? Mm-hmm.
Absolutely. So how do we not penalize people for making progress, right?
Exactly.
Yeah, of course. Absolutely. So, I mean, the funding that funds this program is not income based. So it's predominantly general funds. There's also some state HAP funds, but the continuity of care in this program is really what's going to be critical. So if the person is initially engaged in case management on the street, and it's 6 months before they get into, say, whatever next looks like, whether it's a housing opportunity, whether it's a residential program or shelter, whether it's adult independent living care, the case management team can stay with them past that introduction into that new housing program. And that was built out intentionally so that there's longer term stabilization, because often, even when something like, to your point, something positive happens, it doesn't mean that it's not a significant stressor. Right.
Mm-hmm.
So bridging that gap and ensuring that there is stability and a handoff that is going to be successful for the client, whether that's 3 months, 6 months, a year, it was sort of built into this model intentionally to address that.
Thank you. That's wonderful news.
Commissioner Vasquez. Let's see. Any other hands? I do not. Commissioner Hester, no. Okay.
I just wanted.
Oh,
Sorry.
Go ahead.
I just wanted to say that this program is so important, and I thank you for answering all of the questions that other commissioners have asked. I'm also in support of this.
Okay. Commissioner Hubbard, nothing. Let's see. All right. So I appreciated the presentation by staff and obviously appreciated the questions by the commissioners. I want to make a few statements before I look for a motion on this matter. One, I know the county had talked about that they wanted to start identifying the population by name, not by number, and really putting a face on it. And so I think, this program and the work that Path and Father Joe's are going to do is going to be an essential component of that. So when you talk about, by person, not by geographic area, that really aligns well with the focus of, the humanity of a name and a person who may be struggling. So I like that. One of the things I would ask that Lisa, that for the team to do is, I think the city has not. Let me rephrase that. I think we can do a better job of making people aware of the rapid response to mobile crisis unit. Whenever I mention that, some look at me like, we have one, and I know that the statistics and the stats early have been fairly impressive, but but we're not. So if we could get more detail as the commissioners about how that's going on a quarterly basis, that would be wonderful. I think it's important that we find ways to promote that as a resource, especially with this new contract. I think we have a role to be in being a voice for this essential service that is really about the care and compassion for people struggling with homelessness who may have additional needs around the mental health side. And so figuring out how we promote that, even on our own social media channels, I think is important, but we need to do a much better job. And I think that it'd be a benefit for the commissioners to know more information each quarter about the number of calls and when you can break it down by geography, where are we seeing the majority of the work happen. There is there's also, I have a question around Balboa Park, Lisa. We're getting more and more calls and questions about Balboa Park. There are a lot of people who are really concerned that the city's crown jewel is being ignored because of the focus on the gas lamp and down the specific downtown area. So any additional information you can provide us around the efforts and work that is attached to Balboa Park would be great as well. I do think that is the number of complaints is increasing dramatically. On the pay study, I think it's important for the commission and my colleagues and the commissioners. We have to do a really good job leading up to next year's discussion by the city on budget. I think that Lisa, the question is when will that, I think I heard someone earlier say we're doing a pay study now. When will that information be complete? Because I think the city needs to understand that, the county needs to understand that. We have to do a better job of being a voice of what is the appropriate pay structure so that the contracts reflect that and we don't lose people because we're paying below what that pay structure is. So when will that study be done, and will we have enough information to truly have a conversation with the city about what's necessary for these contracts?
That's a great question. Actually, we are just finalizing that, and we're just having internal conversations of when we take it to the board for review, as well as briefings with council members. So what we're seeing, just sort of some early information, what we're seeing is that frontline staff are being paid at around 60% or less of what MIT identifies as the living wage for the San Diego region, so the city of San Diego region. The MIT living wage calculation and indicator is really considered the gold standard by compensation consultants. So they look at that. And we are also far under what other high need regions of the country pay for similar frontline positions. So not only we're about 60% of the living wage, most frontline staff, based on the wage indicators we're looking at, can't afford a 1-bedroom apartment in San Diego without being rent burdened. So we're seeing high need there. What we've really done in looking at this is made some recommendations about benchmarking frontline positions against first responders. Because a lot of what frontline staff deal with is helping people get through crisis and stabilize. And so they are dealing with crisis situations. They're dealing with humans that are suffering and struggling to get back on their feet, whether it's a financial displacement or whether it's something much more significant like the population we're talking about today. We ask a lot of our frontline staff, and we really need to think about re-benchmarking them towards fire, emergency response, police response, those types of frontline responders that we ask so much of. And that's the recommendations that will be coming forward. I think the conversation will really be had, how do we initially start to right size over a 2 to 3 year phase in? And I would recommend, frankly, a 2-year phase in. And then how do we keep competitive over time, year upon year, is going to be critical. The other thing that frontline re-benchmarking will do is also impact other positions that need right sizing, right? So we anticipate basically that'll be a conversation we can have internally with you, Chair, and our council president and council members around how we bring this forward, because we're ready to bring that work forward. And I think it's good when we know that the council is really working on their initial budget memos. They're starting much earlier this year. It's a good timing to bring that forward. I did want to just comment on your comments around how do we share information and data around this? How do we better socialize what we're doing? One of the things that we're looking at here, obviously, exiting back into housing is one of the main indicators, but we know for this population, a lot of forms of stabilization are important. So we're really looking at how we look at other health outcome indicators to help show progress towards a goal, because we're not necessarily going to go from 4 to 8 weeks of case management to housing, right? This is a very different population. So we're looking at health indicators so we can better track progress and report out on outcomes too, which I think is going to be important.
Yeah, I agree. And I will go back to something that Vice Chair Klempner said. I think that what people see, perception's reality. And when they come downtown or they're in Balboa Park and they see a situation that involves, maybe mental health, then then there's this general assumption that, well, there's just the mental health problem is completely out of control. Nobody's paying attention to it. It's getting worse. And this is a failure of the city. And so again, there's a segmentation of the homeless population, some who are struggling with economic strife, some who are in transition in between places, and some who really do need the wraparound services and mental health care. And I think that the better understanding of the data and the sharing of the data, so you have a better idea of where it's happening and what's going on, is going to be important. And so I'll make my final comment. Lisa, I think that this program is incredibly important. I appreciated the presentation. I'll remind everybody that, and I will continue to say this, there is not one single element that will address this problem. It's a portfolio of options and opportunities. And I am reminding people, my colleagues, reminding people that we talk to that it's not just about housing. It's not just about shelters. It's about services such as what PATH and Father Joe's are going to provide as well. So you have to look at the full portfolio as we look at how we address this situation and this problem and try and improve it. And so appreciate what you guys are doing. Would like to get a little more information. That PACE study is going to be very, very important. I'd ask that you guys fast track finalizing that so we can get it into the hands of the city so that we can try and create a pathway over a 2-year period where we're paying people appropriately and keeping them as dedicated and committed public servants to this situation. And I think that's going to be really important, is that we show them over a 2-year period that we really care. So, all right. Seeing no further hands or.
Sorry, Chair, I have one more question,
Sure.
if I may. I apologize. I neglected to check my notes before I ended last time. If we find this program to be impactful, will there be an opportunity to scale it up, and how would we do that? And related to that, I know that we're looking at 50 people estimated for a year. And this is very intentionally a low caseload, with the understanding this is intensive need here. And so the worst thing we could do would be to try to address the entire need all at once with and spread people too thin and kind of fail at all of it. But if it's 50 this year, do we have an estimate of how many people we think fall into this category in total? And presumably, if this was working well, that would be what we would be aiming towards scaling up to. So those two related questions. And then I would be happy to make a motion when we're done. Yeah.
I thank you for that question, because that's been on our minds. So I think we'll have a better idea as over the first 2 months of this program launching of what that overall number looks like. We know that it's a small segment of the population, but we know that from the HMIS data that we do look at for all the programs the commission runs, that we often see numbers that where we have sort of like every disabling condition you can think of ticked off in HMIS running at around 10%, right? So it's a little hard to tell. I think we'll know in 2 to 3 months, we'll have a much better idea. I will say that scale has been on our minds. We are just finalizing today application for increasing the multidisciplinary outreach team to the COC unsheltered NOFO. It's one of the first NOFOs of its kind that HUD put out, 22 million potentially for our region. It is a highly competitive NOFO, and it also gives certain scoring points for how dire your situation is. So we're not in the top tier, we're competing in the second tier. There's still a great opportunity. Tamara Kohler from RTFH has really been focusing on this. And I do want to call out that we really appreciate RTFH's contribution to this effort, $194,000 in HAP funds that they've contributed on top of the $500,000 from City Council to really launch this first year program. So the application that we're making for that NOFO is approximately $2 million to basically triple the size that we're at now. So rather than having one team where we're starting today, looking to have 3 teams out in the field. Knowing that that is very competitive, we are also tracking very closely some of the opportunities that may be coming down through state legislative efforts, targeting higher need populations, even potentially where we can partner with the county and really kind of thinking that through, because we're going to need more than one team out there, I believe.
Fantastic. Thank you for that. I'd be happy to make the motion.
All right, I have a motion by Vice Chair Klempner. Do I have a second on item 100?
Sorry, before you make the motion, I do want to say, Mitch, since you have mentioned my name, I just wanted to show my support in this. And, you know, I really think that staff is doing a great job. This is something that definitely needs to be addressed, mental health. And I know not as eloquent, I may not be as eloquent as everyone else, but it in no way means that I am any less passionate. So I just wanted to say that. And I realize sometimes staff just needs to hear that, verbally, that we are in support. So I am in support of this. And I think that it's great, long overdue. And I'm hoping that it's successful. I mean, I know it's going to be a long road and expensive, but it's something that's needed, because in the long run, it becomes more expensive if we don't address it. So,
well said. And I think we all agree with your words. Okay, so we have a motion by Vice Chair Klempner. Is there a second?
I'll second.
A second by Commissioner Hester. All right. So with that, I will move to, as I say your name, please, are any more comments on the motion? All right, as seeing none, as I say your name, please state your vote on the motion. Vice Chair Klempner?
Aye.
Commissioner Benvenuto?
Aye.
Commissioner Hester?
Aye.
Commissioner Hubbard?
aye.
And Commissioner Vasquez?
Aye.
Thank you very much. All commissioners who voted in favor, I will add my aye vote as well. And which means the motion carries unanimously. All right. Seeing no further agenda items, I will conclude that today's special board meeting, and the meeting will be now adjourned at 9:55 a.m. Everyone, please be safe, and we will see you next week. So thank you very much for your time this morning, and thank you to staff.